Welcome, everybody. We are very, very, very happy to have today an extraordinary speaker in our webinar. It's the first webinar 2025, so Happy New Year to everybody from our side. And we are very much looking forward to the presentation of Professor Michelle Williams, who is Professor for Cardiovascular Imaging from the University of Edinburgh, on what is relevant in coronary artery imaging, plaque, stenosis, or flow. Nobody could give a better presentation, I would say, about this topic, because Michelle Williams is a super expert in this regard. So many high-ranked publications on this topic. Major author of the Scott Hart trial. So we are very much looking forward, and we are really honored that you join our webinar. Thanks, Michelle.
Thanks very much indeed, Hatham. It's a real pleasure to be here, and I'm delighted to talk about what's basically one of my favorite subjects. As I said earlier, I could talk about this topic all day, basically. It's my job to do that. And I'm going to talk about what matters most in coronary artery disease: stenosis, plaque, or flow. I've got some disclosures there. And I'm going to talk about each of these things separately, and then I'm going to talk about putting it all together. Now, the first thing to say is there is a huge amount to talk about each of these topics. I could easily give an hour-long talk on every single one. So there's no way we're going to cover everything. And we're also not going to cover every imaging modality because, well, I could talk for an hour on each of them as well. I'm going to talk a lot about CT because that's one of the things I spend most of my time doing. But I also do PET and I also do MRI, so we'll have a scattering of that as well in the talk. So let's start with coronary artery stenosis. And the thing that I think about with coronary artery stenosis is this really does have a long history. The heart is a pretty incredible structure. It beats 2.5 billion times in your lifetime, and it never gets a day off. And cardiovascular disease affects an enormous number of people around the world. So 620 million people are estimated to be living with cardiovascular disease in every single country in the world. And it kills over 20 million people every year. So it's a really important condition to consider. And we've been doing invasive coronary angiography looking for stenosis for a long time. Here, for example, is a nice stenosis in a vessel, which was treated with a stent. And one of the great things about invasive coronary angiography is you can direct people towards revascularization, balloon angioplasty, stenting, or maybe bypass grafts. On the right here, we've got a nice example of a stent and several bypass grafts, actually. But these are from CT imaging. So pretty much all of my talk from now on, I'm going to be talking about non-invasive imaging, but we always have to think about invasive imaging as well, because it does have a role. It's all about the right test for the right patient at the right time for the right clinical question. So thinking about CT, again, we've been thinking about this for quite a long time. This is Sir Godfrey Hounsfield, the inventor of the CT scanner. And when he gave his Nobel lecture in 1979, he said, a further promising field may be the detection of the coronary arteries. At that point in time, they already knew that they could image the heart. They just didn't quite have the technology that was needed. And the technology for CT scanning has come a long way from the 90s, when we could see roughly where the coronary arteries were with single slice scanning, all the way up to the latest generations of CT scanners and beyond. I need to update this slide with photon counting CT scanner images, which take us to even more detailed imaging with better resolution. And now we can see inside the coronary arteries and also outside the coronary arteries. And we'll come back to that. Thinking about stenosis, we've known for a long time that we have a great diagnostic accuracy with CT coronary angiography compared to invasive coronary angiography, particularly the ability to say coronary arteries are normal and fantastic sensitivity. The specificity falls off a little bit with heavy calcification, dense structures, but with photon counting CT, our diagnostic accuracy is getting better again with that. So we know we can diagnose stenosis well. And we've got various ways of classifying these. You can see on the left examples of patients with normal, non-obstructive mild, non-obstructive moderate coronary artery disease, and then the greater than 70% stenosis obstructive coronary artery disease. And we have various classification systems for how to interpret these stenosis. This is an example of the CAD-RADS classification, all visually assessed stenosis severity, different potential treatment recommendations, different implications for further testing. So with that background, several large multi-center studies have been done looking at what the role of this is in clinical practice. And as Hatem mentioned, the Scott-Hart study is one that I've been involved in. So Scott-Hart is a large multi-center randomized control trial looking at patients who attended the Rapid Access Chest Pain Clinic. That's outpatient cardiology clinics with symptoms of suspected angina due to coronary heart disease. So your stable chest pain patients or your chronic coronary syndrome patients, depending on the different ways you want to call it. We recruited patients across 12 centres across Scotland, half having a CT scan, half not having a CT scan, and we've been following up the patients ever since. The initial results of the Scott-Hart trial showed that we changed the diagnosis in a quarter of the patients, and this included both cancelling invasive angiograms and medical therapy for people who had normal coronary arteries, and also starting patients on new preventative therapy or organising further testing if they did have coronary artery disease. We changed the investigations in 15% of patients. That was a lot of cancelling of invasive coronary angiograms and functional testing for people who didn't need it. And we changed the treatment in 23% of patients. And that was a lot of starting people on medical therapy where the risk scores and the clinical assessment said they probably didn't need a statin, but the CT scan showed that they had coronary artery disease and might benefit from it. And we showed at 5 years that this led to a halving of the rate of fatal and non-fatal myocardial infarction in the people whose management was guided by CT coronary angiography. We've gone on to follow up these patients ever since, and this year we'll be publishing the 10-year results of the Scott-Hart trial, which we presented at ESC last year, so do look out for that later this month. At the same time that Scott-Hart was going on, another big study was happening in the US with 10,000 patients, the PROMISE trial. They did something slightly different. They compared CT coronary angiography to functional testing, and they showed that there were similar outcomes in both groups and fewer invasive coronary angiograms that were normal, so less unnecessary invasive coronary angiograms in the CT group. And then more recently, the discharge trial, which maybe some of you have taken part in, and this is another large multi-center randomized controlled trial, again answering a slightly different question. It recruited nearly just over 3,500 patients with stable chest pain who'd been referred for invasive coronary angiogram, and half of them had a CT scan prior to the invasive coronary angiogram to see if the invasive coronary angiogram could be cancelled. The primary outcome was cardiovascular death or non-fatal myocardial infarction or stroke, and that was similar in the two treatment groups, showing that both options are a safe option for patients. But importantly, there were fewer procedure-related complications in the CT group. So invasive coronary angiography, it's got invasive in the name. There are risks to doing that. CT came out as the safer option. And all of these things have impacted our guidelines. In the UK, we have the NICE guidelines for recent onset chest pain of suspected cardiac origin, last updated in 2016. And at that point, using CT became the first line of our care in the UK. So we've been doing this for a while. Other testing, functional testing, invasive coronary angiogram, obviously available for patients as required, but our first line is CT. ESC has the chronic coronary syndrome guidelines, 2019, and then most recently updated 2014, and the American guidelines updated in 2021. And all of these show how we can use these different imaging tests for different patients depending on risk and symptoms and background coronary artery disease. And this is all based on just stenosis alone. So all of these research studies, big research studies, all of these guidelines, they're all primarily just about stenosis. But CT and PET, which I'll come on to in a bit, can do more than just look at stenosis. We can see the atherosclerotic plaque, and it's very apparent on these images that some of the plaque is calcified and some of it is non-calcified. That's the most basic differentiation we can do, but we can do much more than that now as well. So let's talk about atherosclerotic plaque. I'm going to divide this into two bits. I'm going to talk about culprit lesions and plaque types and specific plaque features, but also about how much plaque we have, because that is coming out as a particularly important thing. So let's start with the vulnerable plaque. It's got a variety of different names: high risk, vulnerable, adverse plaque. Everyone calls it something different, and we can image it in lots of different ways. So here on the left, we've got the classic thin cap fibroatheroma, the pathological correlate of your vulnerable plaque, the one that we think causes many, not all, but many myocardial infarctions. We've got intravascular ultrasound and invasive imaging tests in the middle, and then our CT on the left. Generally, these are the plaques that you look at and you think, oh, that looks nasty. These are the ones that are likely to be high risk. And on CT, we've got a few ways of classifying these. We've got positive remodeling, low attenuation plaque, spotty calcification, and the napkin ring sign. So let's have a look at those. So positive remodeling is when we have an outward remodeling of the coronary artery. When plaque forms, in some patients, it narrows the coronary arteries. In other patients, it first expands the coronary artery outwards as the lumen tries to be maintained rather than causing a narrowing. And this is called Glagov remodeling. And this is a particularly important high-risk plaque feature in all of the studies. So this is one to look out for. Low attenuation plaque is when you have within a non-calcified plaque a focus of attenuation in the fat range, so less than 30 Hounsfield units. It's thought to correlate with the necrotic core of that thin cap fibroatheroma. It's one that's a little bit more difficult to identify. It's easy to overcall this. A true thin cap fibroatheroma is a really high-risk feature, but it can be overcalled. So it's an important one to look out for, but beware of overcalling. Spotty calcification is defined as tiny little flecks of calcification, less than 3 millimeters. I think this really needs to be within a non-calcified plaque rather than just specks of calcification, because we have specks of calcification that are very low risk. But if you've got tiny bit of calcification within a nasty looking plaque, that might be a high risk feature. But actually in more recent research, it's not proving that specific a marker. And then we've got the napkin ring sign, which is kind of a combination of positive remodeling and low attenuation plaque and some other things. So we've got here an example of an impressive napkin ring. The lumen's in blue, and in pink is the non-calcified plaque. And then in orange is the central low attenuation. And we also have a peripheral high attenuation ring in yellow. Now, what this is, we don't really know. Is this microcalcification? Is this a little dissection? It's probably a combination of different things in different people, and this is a particularly high-risk feature. So in registry studies, these have been shown to be associated with subsequent outcomes and poor outcomes. The more feature-positive plaques you have, the worse outcomes you have. In the Scott-Hart trial, we also showed that having more of these features, particularly positive remodeling and low-density plaque, was a marker of having worse outcomes. But this wasn't independent of overall plaque burden, which I'll come back to. And then there's been a nice meta-analysis done a couple of years ago, looking at across all of the different imaging modalities, how do these high-risk features do in terms of prediction? They looked at 30,000 patients in 30 studies, and the presence of one or more of these high-risk plaque features was associated with an increased risk of subsequent events like MACE. Not perfect, but there was an increased risk in these patients across the different studies and different imaging modalities. But we've got other ways to look at these vulnerable plaques. We've got invasive imaging, non-invasive imaging, we've got CT, we've got MRI, and I thought I'd take the opportunity to show you a few PET radio tracers that can highlight different aspects of the vulnerable plaque. We've just had our new total body PET scanner installed here, and I don't have any images quite yet to show you of that, but I'm really excited to do this sort of imaging with the improved resolution of the new scanner. So these images are all with our previous PET CT and PET MRI scanners. First, this is calcification. So sodium fluoride, 18F sodium fluoride is a marker of microcalcification. And we've looked at this in lots of different patient groups, but this is an example of a patient group with myocardial infarction. Nick Joshi showed that the culprit plaques had higher uptake of sodium fluoride compared to the non-culprit plaques in patients with myocardial infarction. And the few where it didn't identify the culprit, we actually wonder whether the culprit adjudication on the invasive coronary angiogram might have been wrong. So it's a very interesting trace for looking at microcalcification. And we've gone on to look at that in a multi-center study led by David Newby, looking at 704 patients in the Prefer study and looking at microcalcification activity across the entire coronary tree, the CMA. This was associated with cardiac death, non-fatal myocardial infarction, and all-cause mortality, but not with revascularization. So calcification plays an important role in these active plaques. We've also got a radiotracer that looks at thrombus. So 18F-GP1 looks at thrombus within the plaque. And this is an example of a patient who had an ST elevation myocardial infarction. You can see the invasive coronary angiogram on the right with the thrombus in situ there. That was aspirated, and the next day they came for a PET CT, which is on the left. You can see on the CT that irregularity in the wall of the coronary artery, that's the thrombus, which lights up beautifully with the GP1 radiotracer. And then we've got a fibrosis radiotracer called FAPI, Gallium-68 FAPI. This is a beautiful radiotracer. It lights up like a Christmas tree. Really nice imaging of activated fibroblasts in this PET MRI example of a myocardial infarction. So you can see the inferior infraseptal late enhancement, recent myocardial infarction in this patient, and it lights up. And this ongoing fibrosis lasts for quite a while after myocardial infarction. So the next thing with this is to look at it in the vascular structures and see what we can see there. And then this is work from Jason Tarkin looking at gallium-68 dotatate, a somatostatin receptor subtype binding agent, which these are on macrophages, so in active inflammation, like in this patient, we can see inflammation. So you can see across the different radiotracers and the CT imaging and the MRI imaging, there's so much more to uncover about plaque. We're really just starting to understand different plaque types. But a lot of the research has suggested that actually it's not just about the type of plaque you have, how much plaque you have might be really important to understanding your cardiovascular risk and guiding what medical therapy or invasive therapy you might benefit most from. We've been doing this for a long time again, so coronary artery calcium score is one of the most basic way we assess plaque across the coronary tree. And in pretty much every cohort of patients that's ever been studied, coronary artery calcification is the biggest marker of cardiovascular events and often all-cause mortality as well. I think bronchiectasis is the only cohort that I've ever studied where it wasn't the most important thing. Turns out bronchiectasis severity is as important as coronary artery calcium score in patients with the range of bronchiectasis that attend bronchiectasis clinics. It's quite interesting. And I think coronary artery calcification on thoracic CT is a very important area for future research, particularly lung cancer screening and routine imaging. It's an important thing to look out for and can diagnose disease when patients might not otherwise know they have coronary artery disease. But coronary artery calcification is not enough on its own in symptomatic patients. We looked at this in Scott Hart, and we found that in patients who had a calcium score of 0, 16% had coronary artery disease, 2% had obstructive coronary artery disease, 2% had visually assessed adverse plaque characteristics, and nearly 13% had a high burden of quantitatively assessed low attenuation plaque. So on CT coronary angiogram, we've got a variety of ways that we can classify burden of plaque. There's lots of different scoring systems, some more complicated than the others, all show pretty much the same thing, more plaque, worse for you. And most recently in the CAD-RADS classification system for reporting coronary artery disease, the P modifier has been added. And I'm very pleased about this because it takes CAD-RADS from just identifying the most severe stenosis to giving an idea of the global burden of coronary artery disease, which was always the important thing that was missing from CAD-RADS. So there's lots of options for how you add this P modifier to the classification, and so that it is something that people can do routinely in everyday clinical practice. But again, we've moved on from just visual classification of plaque burden in the research studies, and this is coming to clinical practice very soon. In the next 2 to 5 years, I reckon we'll hopefully have inbuilt plaque quantification as part of our routine assessment of CT coronary angiograms in the softwares. This is an example of a quantitatively assessed plaque with the AutoPlaque software. I work closely with Damini Day and her team at Cedars-Sinai, using this and many other softwares. So this is a patient with quite bad coronary artery disease. The lumen's in blue, the non-calcified plaque is in red, and the low attenuation plaque is in orange, and the calcified plaque is in yellow. And you can see all of the extra information that this form of quantitative analysis can give us. There's lots of different softwares that can do this now. One of the things that's important is that they all come up with slightly different numbers. So we do need some standardization of what all this means, particularly if we're going to use this for following up patients or guiding management and treatment choices. This, although they all look different, is the same coronary artery assessed with lots of different softwares. So standardization is very important. The other thing that's really important is automation. I do not have the time to draw around coronary arteries in my routine clinical practice. I need to be reporting scans very fast. My reporting list is very long. So I need a lot of help from the machine learning tools that are being developed to actually make this a reality. Unfortunately, some of these already have machine learning built into them to make things a bit quicker for us. So what does this sort of quantitative plaque analysis mean? Well, again, looking at the Scott-Hart trial, we showed that in people who had a myocardial infarction or coronary heart disease death, they had more of all of the different types of plaque. This is an example of a patient who had a particularly high burden of low attenuation plaque. They've got quite a lot of non-calcified plaque throughout the vessel, but I've got a 3D reconstruction there that focuses in on a beautiful thin cap fibroatherioma with non-calcified plaque, central low attenuation, highlighted there in orange for you. And 4 years later, this was the site of their myocardial infarction. So you can see that these high-risk plaques and plaque characteristics, it's not an instant thing. It can be a long-term thing as well. So in the Scott-Hart trial, a low attenuation plaque above 4% quantitatively assessed was shown to be associated with a 5 times increased risk of myocardial infarction. And this was independent of other markers of cardiovascular disease or risk, so calcium score, obstructive coronary artery disease, or the cardiovascular risk score. Importantly, it was shown to be as good a marker of high-risk disease in men as it is in women, maybe even slightly better in women than men. A little bit more work needed on that in the future, I think, as well, looking at the differences and similarities in how plaque is present and importantly progresses as well. Deep learning, sorry, we've got a helicopter outside landing just on the roof, so hopefully the sound isn't going to interrupt this too much. Deep learning plaque segmentation has definitely improved things from a time point of view. So the initial Scott-Hart analysis, that would take between half an hour and an hour to do this sort of analysis. It was 2 years of my life, but now we can replicate this in a matter of minutes, which is really taking this to the next level. And it's not just about stable chest pain patients. We can also talk about acute chest pain patients as well. So this is the rapid CTCA study led by Alistair Gray here in Edinburgh. And one of my postdocs, PhD students, looked at quantitative plaque analysis in these patients, looking at the 1-year event rate. And he found that patients with a high low attenuation plaque burden had an 8-fold increased risk of subsequent events. And this was more predictive than our classic ways of assessing risk in the acute chest pain patients, like the GRACE score. We can also use it to differentiate different types of myocardial infarction. So this is type 1 myocardial infarction is your classic thrombosis event. Type 2 myocardial infarction is a supply-demand mismatch situation. And we've got cohorts of these patients in various studies here in Edinburgh. And looking at the differences in their plaque, we can see that actually identifying type 1 myocardial infarction was much better with the low attenuation plaque. And for me, there's a few things that are the things that are coming next with this. Now we have the ability to accurately quantify disease. We have the ability to understand plaque progression. And this is important for understanding what causes plaque, coronary artery disease to develop and progress, and also how our medical therapies impact that. And one of the important things I think to remember is the sex-based similarities and differences in disease. This is from the Paradigm Registry, one of the largest plaque progression registries so far. And they showed really important differences in how plaque changes in men and women. Women had less total and non-calcified plaque at baseline, slower progression of this over time, but a similar progression of the calcified plaque, which is really interesting, thinking about both the similarities and differences and how we're going to address that going forwards. Another next thing to do with coronary artery disease is radiomic analysis. It's no longer just about attenuation. We can drill into these plaques and drill into the CT images in much more detail and get these additional texture-based features and other features that we call radiomics. It involves a lot of machine learning and feature extraction to understand these features and work out how to classify them and use them. But there's early work showing that this has potential prognostic implications and could be used to identify better particular subtypes of plaque. Obviously, again, there's a lot of work here that needs done on standardization and automation of this. Different CT reconstructions give you different pictures and different radiomic characteristics. And particularly with photon counting CT, we know already that this is going to cause us new and interesting challenges. And I've talked a lot about plaque. There's also what's outside the plaque to consider as well. The pericoronary adipose tissue attenuation or pericoronary adipose tissue radiomic characteristics might also be useful for predicting events, predicting high-risk patients, or predicting who might benefit from medical therapy. It's very early days for this sort of work. We don't really know what this is. We know it's important, but we still don't know what it is or what it's showing us or how to treat it, or can we treat it? Is it systemic? Is it local? It's one of those many interesting things about coronary artery disease that we still don't know. So that's plaque. So in the last part of my talk, I'm going to talk about coronary blood flow. And for me, this is all about symptoms. Many of the plaque-based things about risk of heart attacks, but we do have to remember that often we have patients with symptoms and we need to think about how to work out what's causing those symptoms, and also can we treat those symptoms and who best to have which type of therapy. So for me, blood flow assessment is about symptoms. And there's quite a lot of things to think about here. We've got perfusion, which is about how much blood is in the tissue. We've got the myocardium, and we've got flow, which is about how the blood gets to the myocardium. And we've got fractional flow reserve, which is a ratio, pressure ratio that I'll come on to, which is telling us about how that blood is getting or are likely to get to the myocardium. All of these things tell us different but slightly overlapping bits of information and help us build up a picture of coronary artery disease beyond just the coronary arteries or beyond just the epicardial coronary arteries. And there's lots of different ways we can do this. So we've got MRI perfusion, late enhancement imaging. We've got SPECT and PET, which is give us absolute or relative information on perfusion or myocardial blood flow if you're using oxygen 15. And we've got CT as well. We've got CT myocardial perfusion imaging and CT FFR. So in the last few minutes, there's a lot to talk about there. I'm not going to cover all of these things, but I'm going to talk about some general overview pictures. The first is going to be perfusion imaging, and I'm going to focus in on CT perfusion because I've done a lot of work on that over the years. And in the ischemia cascade, this is about identifying hypoperfusion. It's about understanding the blood vessels beyond just the epicardial vessels. We give patients some form of stress and we image them at rest, and during stress. And the stress may be physical, pharmacological, maybe treadmill, maybe adenosine. There's lots of different options for this now. And the fundamental thing that we're trying to identify is your reversible ischemia defect. Normal myocardium is normal at rest and stress. Fixed infarcts are abnormal at rest and stress. So we're trying to find those ones that are normal at rest, but become abnormal at stress. And on the right here, we've got an example of CTs. We've got normal myocardium in this area, but hypoperfused myocardium, abnormal myocardium on the stress imaging. And there's lots of ways to do it. So that was an example of a rest stress CT perfusion, showing that nice perfusion defect. We've got a SPECT scan here, shows similar sort of thing, and an MRI perfusion scan, this time in a patient with multivessel coronary artery disease. And one of the studies that I did quite early on was looking at how perfusion and blood flow are similar and different. So we did CT myocardial perfusion imaging and also MRI and also invasive coronary angiography and fractional flow reserve, but that's a whole other talk. But we also did oxygen 15 water PET imaging. So these are beautiful CT images. On the left, a rest one, nasty coronary artery, you can see there. Yellowy orange myocardium is normal, but the purpley stuff shows some areas of hyperperfusion, even on the rest scan. And then the stress image, you can see that apical, mid-apical perfusion defect gets much worse. Mainly LED territory, but a little bit right coronary artery as well. And in the oxygen 15 scan, we see the myocardial blood flow, the absolute myocardial blood flow, showing us, yes, there's a large reversible LED territory defect, but also some partially reversible RCA defect as well. And we've now got this as part of our CADRADS classification system, nice ways to describe all of this. And we've got extensive research showing that perfusion is associated with prognosis. It's another one that pretty much every study that looks at it with any imaging modality shows worse perfusion, worse prognosis. How we use this in clinical care can sometimes be challenging though. And then we've got fractional flow reserves. So traditionally, this is an invasive measurement. You're measuring the distal coronary pressure compared to the proximal coronary pressure at maximal hyperemia, so during an adenosine infusion. So it's a ratio that we get during an invasive coronary angiography stress test. And there's lots of research that shows that this can be useful for guiding therapy, particularly stent implantation. This is data from the FAME study, which is going back a bit now. But more recently, techniques have been developed using computational fluid dynamics to model this from resting CT coronary angiography. So it's not an actual measurement that we're making, it's a model and synthetic calculation that we're using the anatomy to tell us with some very complicated computing. And the sort of stuff that we're using, this CFD stuff, is the sort of things people have been using in engineering for a long time. So wind tunnels, sports cars, this is the sort of maths that we're talking about here. So these are some examples of this CT FFR. We've got an example here, a heart flow based one with normal coronary arteries. So FFR above 0.8 normal coronary arteries, and an example here with nasty coronary artery disease where you can see a low CT-FFR, less than 0.5, showing area of abnormality in the coronary arteries. There's other ways to do this as well. Increasingly, we're seeing AI techniques being developed. None of these have really reached clinical practice yet, but there are other ways to estimate and measure that sort of fractional flow reserve in the coronary arteries. So again, a really interesting area, trying to work out how blood is getting to the tissues. One of the interesting areas for the future is going to be, what do you do with all of the tiny network of blood vessels distal to the epicardial vessels that often get forgotten? And again, this is now part of the CADRADS classification system with nice, simple ways to incorporate that into the conclusions of reports. It's shown to have good diagnostic accuracy, particularly at the high end of the spectrum. It's very good at showing normal coronary arteries. Accuracy about 0.82 overall, with a sort of drop off towards your heavier calcified vessels in particular. And a meta-analysis that Bjarne Neugaard did showed that it has a variety of different prognostic implications across the different studies, predicting death, MACE, spontaneous myocardial infarction, and unplanned revascularization. But how you use this information in clinical practice really impacts whether it's a useful tool and whether it's a health economically valuable tool for your clinical practice. So this is some work done by Taran Mittal down in London, looking at the use of CT-FFR in their clinical practice. They've got 12 centres, 20,000, just nearly 21,000 CT coronary angiograms, and about 2,000 of those were appropriate to send for CT-FFR. They had about a 7% rejection rate. And they found that of the patients they were sending, they had a positive predictive value of only 49%, but a negative predictive value of 76%. So the question is that useful for the individual patient that information is being sent for? Overall, their cost strategy was slightly more expensive with the CT-FFR strategy compared to the stress testing strategy. But again, that depends on what it costs for you for whatever CT-FFR you're using. So there's interesting things here about how we use that information for individual patients. There'll be some that's very useful for, and others it's not so useful for. So we need to think carefully about putting it all together. And this really depends on what the clinical question is. It's all about the right test for the right patient with the right clinical question at the right time. And increasingly, we're realizing that coronary artery disease is not the linear progressive disease that we thought it was. And all those diagrams of beautifully progressing plaques over time are not really what we're dealing with. We have a dynamic, constantly changing situation in the coronary arteries. Sometimes plaques are stable, sometimes they're vulnerable, sometimes they cause clinically apparent myocardial infarction, sometimes they don't. And we really do need to consider all of this information together. We've got the lumen and physiology, your stenosis, your flow, your FFR. We've got the increasing amount of information about the plaque that we're still working out how to use. And then we've got that surrounding microenvironment that we're only just starting on. So coronary artery disease, I've been studying since the beginning of my research career, and I have more questions now than answers, but that for researchers is the best place to be. So I hope you enjoyed that. I'd like to thank all of the people who helped with our research studies and all of our funders, importantly, in particular, the British Heart Foundation, and would be happy to answer any questions.
Thank you very much, Michelle. What a fantastic overview over this very complex and ever-evolving topic on coronary artery imaging. Thank you very, very much. It was really a fantastic presentation. We have indeed several questions in the chat. I start with the first one here by Shehab. How cardiovascular imaging can provide insights into how CAD vulnerable plaques can be identified in women who report atypical symptoms, especially when calcium is not enough in symptomatic patients?
Yeah, very tricky one, yes. So women have often been said to present with atypical symptoms, different symptoms, and there are definitely people who do present with atypical symptoms. But if you look at patients who present, who have myocardial infarctions, they have exactly the same symptoms as the men. There's some great work by one of the research nurses here, Amy Ferry, who's been looking at this. So we do need to think carefully about just thinking about typical and atypical symptoms. Men also present with atypical symptoms and also have coronary artery disease missed in these cases. Could vulnerable plaques help identify? Well, it depends if we're looking for myocardial infarction or cardiovascular risk. Myocardial infarction risk, yes. Cardiovascular risk overall, increasingly it's looking like plaque burden might be the best one. But I think this is an area to keep an eye on going forwards because it is evolving and changing.
Thank you. Another question is there any data on fractal analysis in features of vulnerable plaques? I
You
don't
need
know.
to have a chat to Mark Dewey and Fabian about that, because they're the people who are all over fractal analysis. So far, I've seen mainly perfusion-based stuff,
Yeah.
but I'm sure the coronary arteries are on their radar. The thing with the coronary arteries is they're very small, so your fractals become smaller. So you have to think carefully about what you're looking at, but I'm sure this is something that can be applied there as well.
Okay, there's a question from Andreas Giannopoulos. With regards to plaque quantification and pericoronary fat, would the widespread use of photon counting scanners that is expected in the near future challenge the current cutoffs and our knowledge in these two fields?
Yeah, really important question. So last year we published a paper along with Pal and Marton, the team in Hungary, looking at how plaque is different in from a quantitative point of view across the coronary artery tree in photon counting CT scans with different energies. And yes, at every different energy, the numbers are different. And that's the same for your attenuation and also your radiomic characteristics. So there's a lot of work that needs done here to work out, well, do we just need different cutoffs? Or can we use this to help us more? Which is going to be the focus of many future projects I'm working on. How soon? It's going to take a while. There's a lot of work to do here.
Yeah, I fully agree with these questions. And this is not only true for photon counting CT. Of course, this added complexity with all these energy levels and the increase in voxels that we have available for these small structures. But it's basically true for every scanner that we have. Every scanner is special in regards to his image reconstruction, in regards to his kernels, filters, slice thicknesses, line profiles. And when you go into detail, and we have to go into detail in these very, very small structures, then we get basically, different numbers for every scanner.
Yeah, 100% agree with you, Hatton. This is not just a problem for photon counting CT.
Yeah.
This is something we need to work out across the board for everything we're doing.
Yeah. So further questions. What is your opinion on patients who exhibit chest pain, but in whom CT turns out to show no obstructive lesion above 50%? Tell them all is okay, send them home, perform imaging to try and find evidence for microvascular disease. What is your approach here?
Yeah, very important question. I would say it depends on the patient. Because there are some patients that actually their symptoms are something totally different. There are many people who have musculoskeletal pain, indigestion, loads of other things that it's great that the coronary artery disease has been excluded. And when they're seen again in clinic, actually, when they're told they don't have coronary artery disease, they seem to not have pain anymore. Fantastic. But there are obviously people who do have ongoing pain despite optimal medical therapy and require further imaging and further assessment. My preference is a functional perfusion imaging. I quite like perfusion imaging as a next step in these patients. There's also, from a point of going down the route of microvascular disease, many other ways to assess microvascular disease specifically. And very much depends on the individual patient. I don't see patients anymore. I did start my career as a cardiologist and I used to do cardiology clinics, but for about 10 years now, I've been a radiologist. So I don't actually see the patients anymore out with our research studies. But yeah, it very much depends, I think, is the answer to that question.
Okay, thank you. Another interesting question from Christian Matte here from the cardiology clinics from the USZ. Which one of the functional plaque imaging tools is most close to clinical practice?
So quantitative plaque analysis is the most close to clinical practice now. There are definitely tools that can automatically provide you with how much plaque people have. Total plaque burden is probably the one that will be automated the quickest and widely available the quickest, because it is quite easy to do. A big important question is that going to be better than just us visually going none, mild, moderate, severe for the P classification? So that is an important area that we need to work out from a value added and health economic point of view. Does this change things for patients? Does this optimize treatment? Does this help us choose who would benefit most from our more expensive, newer agents and drug treatments for coronary artery disease? And if it does, great. If it doesn't, well, we're going to need to get the next things online better. But total plaque is quantitatively is definitely going to be one of the first of the assessments to come along. Subtypes of plaque, I think we need to work on standardization before it's a widely usable thing clinically. And then low attenuation plaque, we need even more standardization, and then radiomics, even more work.
Okay, so a combined examination coronary CT PET could be the solution. A question by Klaus Strobel from Luzern.
Yes, although we have to think about radiation dose. We always want to do things as low as reasonably practical. And if a PET is not needed, then we don't want to do it. Even though we might get tiny radiation doses with oxygen 15 and the total body PET scanner, it's still an unnecessary additional test. So it's an option for patients if optical medical therapy is not working to do a PET scan to help guide other things. But CT is a reasonable starting point, I think, and then do other things as required.
Yeah. Another very interesting question here in the chat from Dr. Mendieta. I was wondering what your thoughts are on using total plaque volume versus non-calcified plaque volume as a surrogate endpoint in CAD drug development clinical trials. Do you favor one over the other?
So I love the idea of using plaque as a surrogate marker in clinical trials. I think it's a really important thing to do to help get over that hurdle of having to wait for the heart attacks to occur. So really kickstarting getting things that work into the hands of patients much more quickly. As to exactly what we should use, it's a very interesting question because total plaque burden incorporates calcified plaque, and things like statins and quite a lot of drugs increase the amount of calcified plaque. So total plaque burden, so statins increase the amount of calcified plaque but decrease your risk of heart attacks. So that stabilizing effect, if you just use total plaque burden, you wouldn't you would be having that within your calculations. So that's why non-calcified plaque burden is actually a good one to use in drug trials compared to total plaque burden, because the non-calcified plaque being that higher risk plaque and being the earlier plaque that we want to stabilize is an important one to use. So that's why non-calcified plaque might be a slightly better than total calcified plaque for the drug trial comparisons.
Okay, thank you. Excellent. So with regards to planning revascularization, is plaque burden or CT-based plaque risk topping severity of ischemia as measured by stress imaging preferred, alluding to the results from the ischemia trial?
Yeah, so revascularization is about, would opening up this blood vessel help this patient's symptoms? So actually, in that case, how narrow the blood vessel is might be more useful than the quantitative total plaque burden. Alluding to the results of the ischemia trial, so ischemia looked at optical medical therapy versus revascularization for patients with a reasonable degree of coronary artery disease, and showed similar results. So optical medical therapy is an appropriate thing to consider for patients in many situations. But if they still have symptoms, The question is, what will help you with working out, is this disease the one I need to stent or put bypass graft in? So plaque itself is more about long-term cardiovascular risk.
Okay. So interesting is that the questions, they all go towards the direction of plaque imaging. No, not one question to CT-FFR. So perhaps this is already the answer to your to the title of your presentation. But definitely it illustrates, what is currently going on in the community. Now, when we are looking at plaques, the question from Mihai from our department is, of course, necessarily to be asked. What is your opinion about using coronary CT for screening in asymptomatic individuals?
Fantastic question. So the next thing I'm doing today is going to the imaging department to report some scans for the SCOT-HEART 2 trial. So SCOT-HEART 2, we've recruited 5,000 patients for so far, and it's asymptomatic patients, so screening for coronary artery disease. You have to have one or more cardiovascular risk factor to be eligible to take part in the study. Being over 60 is enough of a risk factor, but if you're between 40 and 70 and have other risk factors, you're also eligible. And like the SCOT-HEART 1 trial, half of the patients will get CT scans and half of the patients just standard care, which is a cardiovascular risk score assessment for patients in Scotland. And I think that will be really important results to help guide us. Based on the SCOT-HEART 1 trial, the patients who had atypical symptoms benefited just as much from management guided by the CT. Hence why we've gone on to screening for cardiovascular disease with the SCOT-HEART 2 trial. And we really have to wait for another 2.5 to 3 years to work out what the results of that will be. At the moment, I don't know. We're definitely going to identify lots of coronary artery disease in people who didn't know they had it. That's going to be a certain one. But does giving them treatment improve outcomes? We'll soon find out.
So you were in the SCOT-HEART 2, you will read the CT cases and you will disclose the result, and then the referring physician can, adapt or start or intensify treatment. Is that correct?
We send the information to the patients themselves as well. So the information goes to the GP, but also the patients, and all of the information about lifestyle modification as well. So it's not just about starting a statin or stopping smoking, losing weight, improving exercise. These are all things that we're giving patients advice on as well. And we're also looking at trying to work out what are the things that improve those outcomes. Is it that they stop smoking, or is it that they take their medication? So we're looking at that as well in the study. So not just who does it benefit, also why and how.
And you will follow them up for years, or what is the plan? Or
the beauty of doing research in Scotland is that we have nationally coded data. So hospital episode statistics, myocardial infarction, prescribing is free nationally, and we have a prescribing information database, and death obviously as well is nationally coded. So we'll be following up patients continuously. The initial results will probably be at 2 years. Plus or minus. But with SCOT-HEART 1, we did 2, 5, and now 10 years. We're publishing this year. And we'll do the same with SCOT-HEART 2.
And from where did you get these patients? I mean, did you go to the street or to the marketplace, or what?
Yeah, so we're sending out letters via GP practices.
Okay.
But also people can self-refer as well. So we do lots of public engagement events. We've gone to football matches. It's been on TV. There's a website. There's lots of ways that people can get into the study. And word of mouth is also another one that has been quite a good way of people coming along. Basically, anyone who lives in Scotland and is registered with a Scottish GP and meets the inclusion criteria can volunteer to be part of this study. And we are looking for another 1,000 people to take part.
So also at football matches is a very good idea. So is it also a risk factor? Did you ever look into that?
Watching football matches,
Yeah.
that's a good one. I like that. So in Edinburgh, we have 2 football teams. One is called Hibs and one is called Hearts. So we launched the study at a Hibs versus Hearts football match back in 20.
Okay. So we're looking really forward to the sub-analysis. Don't forget to do it. Okay,
Need to
very
work
good.
out how to code that on a national basis.
Very good. So I think we had all questions from the chat, Robert.
Yes.
Anything
Yes.
to add?
No, just to say thank you for the brilliant presentation and also this very nice discussion, and seeing how much we still have to do, but also showing us how much we already know, and yeah, there's still enough work for all of us and others to in this field. So yeah, so I just want to say thank you, Michelle, for being with us. It was really a pleasure giving your insights, and I see also the people watching us very happy, very positive about your presentation, and yeah, that's all from my side. Thank you.
Thank you very much for having me. It's been a pleasure to be here today.
Thanks, Michelle.